Next one was an 80-year-old woman with type 2 diabetes who was referred with weakness. She's been taking 𝕊𝕆ₛ𴀵 digoxin and 𝕁-butamide. On examination, she has a temperature of 37.8, a pulse of 98, and she's in atrial fibrillation, and her blood pressure is 118/72. So with regards to her investigations, she has hyponatremia, hypokalemia, her urea is fine, her creatinine's fine, she's got hyperglycemia, and her chest x-ray is normal. So what's the most likely cause of the hyponatremia? I think pretty much everyone's thought 𝕊𝕆ₛ𴀵, because thiazide can cause low sodium, low potassium, and hyperglycemia. So this patient is probably due to 𝕊𝕆ₛ𴀵, and which should be stopped. It's unlikely to be syndrome of inappropriate ADH secretion, of which 𝕁-butamide would be the cause, because hypokalemia wouldn't be associated. And then she also has hyperglycemia with an osmotic diuresis, which would cause dehydration. Addison's disease would be associated with hyperkalemia, hypertension, and a high urea, none of which she has. Next one, you have a 73-year-old lady who comes to the GP with fatigue. Her husband noticed change in her character and her hair becoming thinner. She also complains of constipation, so thin hair, fatigue, and constipation. She has a past medical history of diabetes, which is diet controlled. On examination, she has a pale complexion and her skin is dry. Her pulse is 50, it's regular, 50 beats per minute, it's regular, so she's bradycardic. The rest of the examination is unremarkable. The GP considers anemia and requests a full blood count. Her hemoglobin is 91, white cell count is 7, platelets 147, and the mean cell volume is 105. What's your diagnosis? It's screaming hypothyroidism because of the thin hair, the dry, the constipation, the diabetes maybe as well, the pale complexion, and the anemia. So everything's screaming hypothyroidism. So the presence of tender points is important to diagnose chronic fatigue syndrome. That was one of the differentials. So you need tender points in order to diagnose chronic fatigue syndrome. Depression can cause lethargy in the elderly, but other causes have to be excluded first. Uncontrolled diabetes can cause lethargy and anemia. Hers is diet controlled, which doesn't really mean that it's that bad. And then other features can't be explained as well with other things. So the fact that occult malignancy, that could have been a cause of anemia, but it doesn't explain the constipation and the fact that her hair was becoming thin, the pale complexion, the dry skin as well. And weight loss and GI bleeding are important features, and change in character is rarely a feature as well. Next one, you had a 75-year-old man who was admitted to the medical assessment unit with bleeding per rectum. He was pain-free and hemodynamically stable. His past medical history included myocardial infarction 2 years ago, atrial fibrillation, and COPD. His medications include digoxin, furosemide, warfarin, and a salbutamol inhaler. His hemoglobin was 96 on admission, but 10 hours later, he suddenly became hypotensive and was resuscitated with 2 units of gelfusin and 2 units of blood. An emergency GI endoscopy was inconclusive, but an angiogram confirmed the diagnosis. What's the most likely diagnosis? So it's probably angiodysplasia. In patients who have rectal bleeding, especially if it's fresh blood and it's a large amount, angiodysplasia would be one of your top differentials. And in this case, it was to the point within 10 hours he became hypotensive, and endoscopy, it wouldn't have shown if it was a vessel that was the issue, which is like what it was in this case, angiodysplasia. And then the angiogram confirmed that it was. Colonic tumor would have shown with the endoscopy. Diverticular disease would have shown with the endoscopy. And granulomatous ulceration again would have shown, and ischemic colitis would have shown, but he would have also had like abdominal pain leading up to it, but he was pain-free and hemodynamically stable. So that makes sense with angiodysplasia. So the following can be identified at the endoscopy: a tumor, diverticular disease, and granulomatous ulceration. Ischemic colitis can present with massive bleeding, but they'd have to have abdominal pain as a predominant feature. Okay. Next, you have 34. So a 61-year-old man with a past history of controlled hypertension presents with acute onset weakness of his left arm that resolved over 12 hours. He had suffered with 2 similar episodes over the last 3 months. Examination revealed a blood pressure of 132/82, and he's in atrial fibrillation with a ventricular rate of 85. So his rate is controlled. CT scan is normal. What's the appropriate management in his case? So in his case, because he's getting this transient weakness of his left arm that resolves, he's getting TIAs, we want to prevent that, and we want to prevent the risk of him having a stroke. So warfarin would be the most appropriate step of management in this case. So the patient had 3 transient ischemic attacks in the setting of atrial fibrillation. Compared to a person in sinus rhythm, a patient with AFib has a 5 times increased risk of getting a stroke. And so the stroke mortality is higher in those without atrial fibrillation. Assessment is therefore given with regards to the need for anticoagulation. So you have the CHAD-VASC score. So if it's less than 2, they don't need prophylaxis. But if it's 2 or above, then you need to consider consider starting them on warfarin. So aspirin can be considered if there's other indications. So if they have ischemic heart disease or if they have peripheral artery disease, then maybe you can add aspirin as well. But warfarin is the one that we want to go for because we want to avoid strokes in the future. So higher risk patients should be considered for warfarin with a target INR of 2.5. It reduces the risk of stroke to 68 for stroke with 68%, and it reduces the risk of death with 33%. And the contraindications to warfarin would be, increased risk of bleeding, poor compliance, a patient who's having recurrent falls. Then even if their, score is above 2, it would have to be risk versus benefit. And then you can give aspirin to these patients instead because the risk of them having a major bleed would be lower and it's less hazardous. Okay, cardioversion is indicated in a small portion of patients with AF, but there is a risk of systemic thromboembolism, especially if they've been in AF for more than 2 weeks. And patients with very recent onset of AF, they need immediate assessment and treatment with heparin. And if it's certain that the AF has been present for 2 days or less, then you can consider cardioversion, whether electrical or pharmacological. And then if cardioversion is successful and they return to sinus, they might not need warfarin, depending on their CHAD-VASC score. Okay. The next one was a 78-year-old woman who was admitted 24 hours ago following a fall. The ortho SHO asks for your help because the patient is shouting out on the ward, keeping all the other patients in the bay awake. He tells you that he's not able to reason with her and that she's distracted and incoherent. On arrival, you note that her left leg is shortened and externally rotated, which one of the additional findings would suggest diagnosis of delirium rather than dementia. So out of all these answers, obviously most of them are correct. Positive urine dipstick. If she has a urinary tract infection, that means it's something acute, and then that's delirium, not dementia. A many mental state examination that was done 6 months ago, that might be helpful, but not really. The patient has been given lorazepam with mirfluff, that's not helpful at all. And the patient is febrile at 38 degrees. Again, that would tell us this might be something acute, but you'll never know unless you know the baseline. So that's why E is the correct answer. Unless you know the baseline, then you have nothing to compare it to. So the patient, if she was coherent and compliant on admission, then it might be an acute change, and that would be delirium, not dementia. Okay, so that's the confusion assessment method. They have to be acute onset and fluctuation course, inattention, disorganized thinking, altered level of consciousness. And if you have 1 or 2 or 3, patients must have 1 and 2 and either 3 or 4. So you have to have either the first and the second plus the third or the fourth in order for you to go like, yeah, okay, this is an acute confusion.